Thank you. Good morning, everybody. I welcome you one and all for the today's lecture class, that is stroke. So we'll be discussing about what is stroke and what are the various epidemiological features and management and the problem statement concerning stroke. Stroke is nothing but acute cerebral manifestation of acute cerebral manifestation, and insufficiency, vascular insufficiency, and it is both mentally and physically crippling, and it is also known as apoplexy. Stroke is defined as rapidly developed clinical signs of focal disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than vascular injury. So we should remember that this one thing about stroke is it is rapidly developing clinical signs of focal disturbance of cerebral function. Some part of the brain is affected, some focus of the brain is affected, and it usually lasts more than 24 hours, and it may result in death with no apparent cause other than vascular injury. The cause is mostly due to vascular injury. It involves the blood vessels. So the 24-hour threshold is very, very important in understanding about stroke, and anything exceeding 24 hours or more than that, we consider it as stroke. The 24 hours threshold, the definition excludes transient ischemic attacks and patients with stroke symptoms caused by subdural hemorrhage, tumors, poisoning, or trauma are excluded. So the 24 hours, anything less than 24 hours, we consider it as TIA. And patients with stroke symptoms caused by subdural hemorrhage or tumors, poisoning or trauma are excluded usually from TIA. So anything less than 24 hours, and if there is a focal neurological deficit, we call it as TIA, and anything more than or equal to 24 hours, we call it as stroke. The disturbance of cerebral function is caused by three morphological abnormalities, usually, that is stenosis or the blood vessels, occlusion of the blood vessels, or rupture of the arteries. Now, the dysfunction of the brain or neurological deficit usually manifests in the form of coma, hemiplegia, or paralysis of one half of the body, paraplegia, monoplasia, multiple paralysis, speech disturbances, nerve paralysis, sensory impairment, etc. So once the stroke occurs, there is actually dysfunction of the brain. And how do you know there is a dysfunction of the brain? It is usually in the form of, you see the patient going to a trauma, or there is paralysis of one half of the body, or paralysis of both either the arms or both the legs, that is what is also known as paraplegia. Monoplasia means paralysis of one part of the body, either the right leg or the left leg, or the right arm or the left arm, or there will be multiple paralysis, or there will be speech disturbances. The patient is not able to speak properly, or the patient is not able to talk in a language that is understood by others. There is nerve paralysis, or there may be involvement of a particular nerve which may result in paralysis of a particular part. There is sensory impairment. There may be impairment of the fine touch, crude touch, vibration, or heat and cold sensations in particular part of the body. So dysfunction of the brain is manifested in like this. And when there is a dysfunction of the brain, we should always rule out whether it is due to stroke or due to TIA, depending upon the threshold. Of all these, what we find about the manifestations, hemiplegia constitutes the main somatoneurological disorder in about 90% of patients. So 90% of patients, they have somatoneurological involving the nervous system, involving the what we call the body. We have the somatoneurological disorder. Now, stroke includes a number of syndromes with different etiologies, etymology, prognosis, and treatment. They are listed as below. So, when we talk about stroke, we consider a number of syndromes. And these syndromes can have different causes. So, different epidemiology, different causative agents, different host factors, different risk factors, different prognosis, and different treatment. So, basically, the stroke is divided into two types, that is ischemic stroke and haemorrhagic stroke. Ischemic stroke is basically due to occlusion or stenosis, and hemorrhagic stroke is due to rupture of the arteries. So ischemic stroke is basically can be a lacunar infarct or carotid circulation obstruction, vertebrobasilar obstruction. So ischemic stroke, as I said earlier, it can be due to stenosis or occlusion. It means one part of the artery is stenosed or narrowed down so that blood flow to the part of the brain is not there, or it may be occluded by a thrombus, or it can be occluded by a embolism or embolus. So there can be a lacunar infarct, or it can be a carotid artery obstruction, or it can be a vertebrobasilar obstruction. These are the arteries that may get themselves obstructed, and this obstruction may result in ischemic stroke. The stenosis of the artery can be due to atherosclerosis also. There will be a narrowing of the inner lumen of the arteries. So ischemic stroke will result in this, includes this. Hemorrhagic stroke is nothing but the rupture of the cerebral arteries, and it can be of various types: spontaneous, intracerebral hemorrhage. What is it? Spontaneous intracerebral hemorrhage. Subarachnoid hemorrhage, intracranial aneurysm, arteriovenous malformations. So what are they? Hemorrhagic stroke. So stroke is of two types: ischemic stroke and hemorrhagic stroke. Ischemic stroke is lacunar infarct, carotid circulation obstruction, vertebrobasilar obstruction, and hemorrhagic stroke is again divided into spontaneous intracerebral hemorrhage, subarachnoid hemorrhage, intracranial aneurysm, arteriovenous malformations. Problem statement: stroke is a worldwide health problem. Cerebral thrombosis is the most common frequent form of stroke encountered in clinical studies, followed by cerebral hemorrhage. So what we have is cerebral thrombosis is the most common frequent form of stroke, and this is followed by cerebral hemorrhage. So cerebral thrombosis, cerebral hemorrhage are the commonest causes of stroke, and this is followed by subarachnoid hemorrhage and cerebral embolism, which come next as we consider both in mortality and morbidity. And if we consider the deaths and the disabilities or the morbidities due to stroke, then we consider as subarachnoid hemorrhage, cerebral hemorrhage coming next to cerebral thrombosis and hemorrhage. So what we said of stroke is acute manifestation of cerebrovascular disease, acute severe manifestation of cerebrovascular disease. So we call it earlier as apoplexy. Now, what we should need to understand is stroke from cerebral hemorrhage is more common in Japan than elsewhere. So cerebral hemorrhage is the most common form of stroke in Japan than compared to other countries. Morbidity and mortality due to stroke. Cerebrovascular disease remain a leading cause of death from non-cardiovascular disease. In 2016, cerebrovascular disease accounted for 5.78 million deaths worldwide, equivalent to 10.2% of deaths. If we need to understand about stroke, we need to understand the numbers of people who are affected either in the form of deaths or in the form of disability or morbidity. So 2016 resulted in 5.78 million deaths, equivalent to 10.2% of deaths. Quite a good chunk of all the deaths fine. So the PMR due to stroke is 10.2%. Majority of these deaths occur in people living in developing countries, and 33.72% of the subjects were less than 70 years. So it has been observed that most of the deaths were in developing countries which are in a transition phase, and it occurred mostly in people who are less than 70 years. Cerebrovascular disease is the leading cause of disability in adults. As I said, stroke may result in mortality, morbidity, and disability. In developed countries, the average age at which the stroke occurs is around 73 years. So developed countries it is 73 years, and developing countries it is 70 years. So it means that the average age or the age at which the developed countries are affected by stroke occurs around mostly around 73 years. The probability of a first stroke or first TIA is around 1.6 per 1,000 and 0.42 per 1,000 persons of people population respectively. So stroke and TIA, if you look at the prevalence of probability, so they occur in 1.6 per 1,000 population, 0.42 per 1,000 population here. In less developed countries, the average age of stroke is less due to the different population age structure resulting from higher mortality rates. So less developed countries, the average age of stroke is less than the different populations age structure resulting from the higher mortality rates. Strokes patients are at higher risk of death in the first weeks after event. Means when the stroke has occurred in the initial stage, initial few weeks are very risky for stroke patients because of the result in, and between 20 to 50% die within the first 1 month. So if there are 100 people who are affected by stroke, almost 20 to 50 people will die in the first month. And it depends upon the type, severity, what type of stroke is it, and age, whether it is higher age or what is co-morbidity, whether it is associated with diabetes or whether it is associated with hypertension, and effectiveness of treatment with complications. And how the complications are effectively dealt with. The complications have to be very carefully dealt with, and if they are dealt properly, probably the stroke patients are taken care of. Patients who survive may be left with no disability or with mild, moderate, or severe disability. So sometimes it so happens that people who survive, they don't have any disability, like whether there is monoplasia, hemiplegia, paraplegia, movement of lagging, what we call contraction of one side of the face, or sagging of one side of the face, or turning away of the mouth on one side. So we don't have people with no disability, or there will be mild, moderate, or severe disability. And severe mild, moderate, while as I said, only the face may be affected, or sometimes the speech may be affected, or sometimes there is turning of the mouth at one side if the patient is affected, and it may be moderate or severe also. Where mortality with stroke has been declining in many countries for several years. So stroke, the death due to stroke has been declining. Some of the decline occurred before modern treatments became available. So before modern treatments became available, some of the prevalence of stroke appears to be comparatively less in India than in other countries. It's more likely to increase proportionally with increase in life expectancy. So stroke appears to be less in India than in developed countries, and it is likely to increase proportionally with increase in life expectancy. So what in India, what we find is people usually affected, it may generally affect people in the younger age group. That's what the people in the age group of 40 years or below. That's why we call it something called strokes in the young. So in India, we find more of strokes in the young. People who are affected in the younger age groups, less than 40 to 42 years. And stroke is generally less in India compared to developed countries, and it may increase proportionally with increase in life expectancy. And it has been observed that as the life expectancy increases, we find that there is stroke also increasing. The proportions of stroke is also increasing. Proportion of stroke in young population is more in India than in developed. As I said earlier, people affected by stroke in India are relatively young compared to the developed countries. Causes for this can be rheumatic heart disease. So stroke can be due to rheumatic heart disease in India, or it can be ischemic stroke, or it can be angiopathies due to chronic infections like bacterial meningitis and tubercular meningitis. So tuberculosis may also result in stroke because of tubercular meningitis. So in India, what are the reasons? We should very well remember what are the causes of stroke in India. We should remember primarily as rheumatic heart disease, ischemic stroke, angiopathies due to bacterial meningitis and tubercular meningitis. The total number of deaths due to stroke in India in the year 2016 were about 0.706 million, of which 0.370 million were men and 0.334 million were women. So the number of deaths due to stroke in India are 0.706 million, of which we have men are more affected compared to that of women. So how many men were affected? 0.370 million and 0.334 million. The true death rate due to stroke is found to be 54.2 per 1 lakh population. Now, if you look at the natural history of stroke, we find what are the various causes of stroke etiology, and this may result in pathogenesis or the development of a disease. And if it is less than 24 hours, it may result in transient ischemic cerebral ischemia or TIA, and if it is more than 24 hours, it will result in acute stroke. An acute stroke may result in death, early death, if there is no intervention. And if acute stroke, if the sometimes may result in dependence or an independent life, or the person may be dependent on others or independent life. If at this stage if there is intervention, it may result in labor. So interventions can be at various points. So if in the process natural history of disease, if there is interventions, then it may result in labor. So very important to understand that acute stroke may result if there is no proper intervention, it may result in early death, and if there is interventions, and if there is interventions, it may result in dependence or independent life, and it may result in labor. Sometimes acute stroke may also reoccur, or there will be recurrence of acute stroke. What are the risk factors that are responsible for stroke? Non-modifiable risk factors and modifiable risk factors. As in any non-communicable disease, we said we don't have age roles and environmental factors. But non-modifiable risk factors are risk factors which cannot be changed, which cannot be modified. Number one is age. It has been found that stroke increases with increase in age, and usually in the developed countries it is found in the age groups of 73 years and above, and in the developing countries 70 years and above. In India, what we observe that stroke is found generally in the age group of 40 and below, and it has been labeled as strokes in the young. So it's very important that in India, stroke sometimes if a person is affected by the cerebrovascular incidents, is mostly due to stroke. Sex. Males are generally more affected compared to the females. And one thing that I forgot about age is we find in India more number of more frequency of younger people, and more frequency of younger people who are there, and also the increased population numbers of younger age people. Personal history. So personal history is very, very important. Whether a person is a smoker, or diabetic, or whether he is alcoholic, and genetic history. Genetic factors. If there is a family history of stroke, there is every chance that the person may have some susceptibility to stroke. So it is very important to rule out, to understand that family history, there is a family history of stroke, then certainly the person is vulnerable to stroke. What are the various modifiable risk factors? What are the modifiable risks which we can intervene, which can change, we can modify so that we may control the incidence of stroke? Number one is hypertension, left ventricular hypertrophy, cardiac dilatation, diabetes mellitus, elevated blood lipids, obesity, smoking, glucose intolerance, blood clotting, viscosity, oral contraceptives, drugs like cocaine, amphetamines, and sympathomimetics. Transient ischemic attacks, as I said, if there is a focal neurological deficit and it's occurring, it is identified within less than 24 hours, then we call it as TIA. And these are episodes of focal reversible neurological deficit of sudden onset and less than 24 hours. The 24-hour duration, as I said earlier, separates the TIAs from stroke. So TIAs or transient cerebral ischemias are usually less than 24 hours. And if a person is treated within 24 hours, there's every chance that the recovery is also very good. They show a tendency for recurrence. They are due to microemboli and are a warning sign of stroke. So TIA can occur repeatedly in a person, and it may be due to microemboli. And when they're repeatedly occurring, it is a warning sign and precursor for stroke. Recurrences of TIA. Transitions like demographic shift are shown by increased life expectancy. Number one. Number two, lifestyle of food consumption. Increased saturated fats consumption in the diet, or increase in triglycerides, lipids, or less of fibrous diet, and increased consumption of trans fatty acids, and there is less physical activity. There is no physical activity, or the person is sedentary, and socioeconomic status. Usually, low socioeconomic status are contributed to the emergence of stroke epidemic in India. So, if there is an epidemiological transition, people you can, which I have said in coronary heart disease also, in socioeconomic group, in post-epidemiological transition, it is found in lower socioeconomic status group, and pre-epidemiological transition, it is found in higher socioeconomic. So that is how the TAA can occur. Signs and symptoms. Symptoms start suddenly over seconds to minutes, and in most cases do not progress. It depends upon the area of the brain affected, and more the area of the brain affected, more the functions are lost. We understand the brain to be a sort of a computer chip. If any water falls in the computer chip, that part of the computer is affected, or the entire computer is affected. But one thing we should understand that if a portion of the brain is affected, the nerve endings, the portion of the brain which controls the part of the body, that part of the body is affected. So more the area of the brain affected, more the functions are lost. There is sudden onset of facial weakness, as we have earlier dealt in hypertension also. Facial weakness, fast arm drift, speech abnormal, and time to act or react. So there is sudden onset of fast, that is facial weakness, arm drift, there is speech abnormality of speech, and there is a time we need to act, call the emergency, and it is required to act so that the patient can be shifted to the casualty or the intensive care unit as fast as possible, and proper medical measures administered so that the patient can easily recover. Any one feature or all the three features goes in favor of stroke. So this is abbreviated as fast. So facial weakness or arm drift or speech abnormal, any of these three signs or all the three signs together are very, very important to understand, and they are very compatible with that of stroke, and they go in favor of stroke. So depending upon the involvement of spinal therapy, spinal or medial meniscus, there will be hemiplegia, numbness, reduction in sensation, initial flaccidity, followed by spasticity and hyperreflection. All this you will read very well in medicine when you go to when you are posted for medicine lecture classes, or you must have been already dealt about the nervous system, you will be understanding about these features well. If the brain system is affected, symptoms of deficit due to involvement of cranial nerves may occur. If the cerebellum is affected, there will be altered walking gait, vertigo, and also dyslipidemia. Loss of consciousness, headache, and vomiting usually occurs in hemorrhagic stroke because of increased intracranial pressure from leaking blood compressing the brain. So when there is hemorrhage inside the brain, automatically the cavities of the brain are filled up with blood that is there, and they tend to compress on the what to say different areas of the brain, and this may result in loss of consciousness, headache, and vomiting. So anybody getting unconscious, anybody having a severe headache, anybody having vomiting, and you may very well understand that this may be due to hemorrhagic stroke. If the symptoms are maximum at onset, the most likely cause is subarachnoid hemorrhage or an embolic stroke. So maximum symptoms are found in these types of stroke. So it is very important to understand the typical features of stroke. What are the features of stroke in cerebral hemorrhage, or what are the features in subarachnoid hemorrhage or embolic stroke? Silent stroke is a stroke that doesn't have any outward symptoms. There is no physical manifestations or signs and symptoms involved, and patients are typically unaware that they have suffered a stroke. Silent stroke, in many cases, there are no signs and symptoms. Patients are not aware because you don't find any of the symptoms in them. The silent stroke also causes damage to the brain and places the patient at increased risk of both TIA and major stroke in future. So we should understand that a silent stroke should not be neglected, and this may cause damage to the brain, or this may result in TIA and major stroke in the future. Conversely, those who have suffered a major stroke are also at the risk of having a silent stroke. So those who have suffered a major stroke, they may have a silent stroke. Silent stroke are estimated to occur 5 times the rate of symptomatic strokes. So silent strokes are very common, and they are found with the frequency of occurring more than 5 times the rate of symptomatic strokes. The risk of silent stroke increases with age, but affect younger adults and children, especially those with acute anemia. So silent strokes are generally found to increase with age, and they are usually affect young adults and children who are having acute anemia. Severe anemia is very, very important. That's why it's very important to control also anemia in children and adults. Anemia may be due to various causes, iron deficiency, or due to any GI problems, or any rectal problems, or any problems which may result in anemia, and this may result in also symptomatic, what we call silent strokes. Neurodiagnosis, how they can be diagnosed a stroke in neurological examination, National Institute of Health stroke scale, that is NIHSS, or it can be a CT scan, or magnetic resonance imaging scan, or it can be due to Doppler, or some study of carotid artery, or it can be due to arteriography, and it can be also due to blood test for cholesterol level and bleeding diathesis. Management. Patients are admitted in stroke unit and unmanaged. There is usually many hospitals in Western countries and even in corporate hospitals in India, we have something called a stroke unit, and here where the patients are managed. How the ischemic patients of ischemic stroke are managed? They are managed by thrombolysis. So what we said, usually ischemic stroke is because of the thrombus or embolus, or it can be due to what we call stenosis. So here they are managed by thrombolysis, and normally they are administered with RTPA, that is recombinant tissue plasminogen activator, or it can be due to thrombectomy or removal of the removal of the thrombus by surgery. Earlier the treatment started lesser the brain cell size. The treatment has to act very fast so that the brain tissues and cells are preserved. Larger territory stroke, as in that of MCA, middle cerebral artery, is known as malignant cerebral infarction, and it requires hemicraniectomy, means division of the skull into two halves, where this stroke can be done. Or removal of skull on one side, hemicraniectomy one side. Angioplasty and stenting are viable options in treatment of acute ischemic stroke. So it's very, very important that all these treatments that have to be followed in case of ischemic stroke. In hemorrhagic type of stroke, anticoagulants and antithrombotics can make bleeding worse. So anticoagulants and antithrombotics are generally not administered in case of hemorrhagic stroke because there is always the blood is in a fluid state and the blood immediately spreads over all the parts of the brain. So rehabilitation of stroke should be started as early as possible, physically, psychologically, socially, and vocationally. Physically, psychologically, socially, and vocationally. Newer methods of rehabilitation are transcranial magnetic stimulation, transcranial direct current stimulation, and robotic therapies. So these are the methods we should understand. The newer methods are transcranial magnetic stimulation, transcranial direct current stimulation, and robotic therapies. How do you prevent and control the stroke? Primordial prevention. This is done by interventions targeting modification of behavior such as reduced smoking, alcohol, salt consumption, decreased salt consumption, and increased consumption of fruits and vegetables. So this is dietary modification which has to be followed. So smoking and alcohol are a complete taboo, and salt consumption has to be reduced. We always say that salt consumption has to be reduced less than 5 grams, and increased consumption of fruits and vegetables. Mediterranean style of diet consisting of high consumption of olive oil. So in Mediterranean, they consume a lot of olives and olive oils, and Mediterranean style of diet involves consumption of olive oil, more of legumes, more of unrefined cereals, fruits, vegetables, and moderate consumption of dairy products like cheese and yogurt, wine, fish, and low consumption of meat prevents stroke in 50% of cases. So consumption of wheat is very, very important, and low consumption prevents stroke in 50% of the cases. All these aim at prevention of obesity, diabetes, and hypertension. Other promotive measures are alcohol, avoidance of smoking, and doing regular exercise. So smoking and alcohol are a complete taboo, as I said earlier, and exercise is very important. At least 30 minutes for 5 days, 5 to 6 days, 6 days in a week, 5 to 6 days in a week are very, very important. And secondary prevention strategies include pharmacotherapy with aspirin, dipyridamole, clopidogrel gel to prevent platelets from getting aggregated. Warfarin prevents thromboembolic stroke in patients with non-valvular atrial fibrillation. Other measures consist of effective management of comorbidities such as hypertension, atrial fibrillation, and hypercholesterolemia. Carotid endarterectomy or carotid angioplasty can be used to remove atherosclerotic narrowing of carotid artery. Now, we have a program in most of the countries called stroke control program. In India, what we have is a national program called National Program for the Control of Non-Communicable Diseases like Cancer, Diabetes, Cardiovascular Disease, and Stroke. So, NPCDCS, National Program for the Control of Non-Communicable Diseases like Cancer, Diabetes, Cardiovascular Diseases, and Stroke. That's what we have a program in our country. But generally, in a stroke control program, what has to be done, we'll discuss over here. The aim of a stroke control program is to apply at community level effective measures for the prevention of stroke. So we need to go for certain measures that we can do for the control of stroke in the community. How to reduce stroke in the community? The first priority is control of arterial hypertension. This is a major cause of stroke. So we need to identify high-risk people who are having hypertension, and we need to control the stroke. And this can be done by the optimal methods of using optimal methods on instruments like the sphygmomanometer or even a stethoscope. So stethoscope and sphygmomanometer are very important for screening of people for stroke, hypertension, and thereby preventing stroke. As TIA may be one of the earlier manifestations of stroke, the earlier detection and treatment is very important for prevention of stroke. It is very important to identify whether the person is suffering from TIA, and if the person is always admitted to the health facility on time within 24 hours, it is very important that the person may not go into stroke, and most of the symptoms, focal neurological deficits, can be reversed, and the person can be hale and hearty after recovering from TIA. Control of diabetes is very important. The person should have a strict control of diabetes, and for this, home monitoring of blood glucose and effective contact with the health facility, and maintaining the ideal hemoglobin A1C levels, glycosylated hemoglobin levels are very important for the control of diabetes, and usually elimination of smoking and prevention and management of other risk factors in the population levels are new approaches. Treatment for acute stroke is largely control of complications. We need to control the complications for acute stroke. Facilities for the long-term follow-up patients are essential. So we must be very important that the long-term follow-up patients is very, very important. The education and training of health personnel under the public form an integral part of the program. For any such program, available knowledge and extent of the problem of the community concern is essential. So we need to train the health personnel regarding health personnel as well as the public in understanding about the facts about diabetes, in understanding about the facts about smoking, in understanding about the healthy diet, and what type of diet that should be understood, and how to identify the symptoms of TIA and how the symptoms of stroke by understanding the mnemonic about FAST, facial weakness, arm lift, speech disturbance, and time to react, and whom to call. For example, 108 can be called in India and report that, and they can be transferred to the the health facility as soon as possible. For any such program, available knowledge of the extent of the problem and the community concern is very, very essential. So we have today completed the chapter on stroke. So as I said, stroke or apoplexy is acute severe manifestation of cerebral vascular disease, and stroke may usually be both physically and mentally crippling. The effects of stroke may be physically and mentally crippling, so it will affect physically as well as mentally. And we have a definition of stroke which you should understand. So as I said earlier, stroke is the rapidly developed clinical signs of focal disturbance of cerebral function, rapidly developed clinical signs of focal disturbance of cerebral function, lasting more than 24 hours or leading to death with no apparent cause other than vascular reason. Focal disturbance of cerebral function. So some areas are very unaffected and is usually more than 24 hours, and it may lead to death with no other cause other than vascular disease. So less than 20, the 24-hour threshold is very, very important. Less than 24 hours we find as EAD. So what are the various types of stroke? We should know the various types of stroke. Basically due to stenosis, occlusion, hemorrhage, and they're basically divided into two types: ischemic stroke and haemorrhagic stroke. Ischemic stroke is again divided into pulmonary infarct, the adequate circulation obstruction, the tubular obstruction. Haemorrhagic stroke is spontaneous intracerebral hemorrhage, subarachnoid hemorrhage, intracranial embolism, intravenous malformations. Cerebral thrombosis and cerebral hemorrhage are very, very common types of stroke, followed by subarachnoid hemorrhage and subarachnoid thrombosis. So what we need to understand is all these are very important to understanding of stroke. Sometimes a stroke can be a long question, define stroke, and what write briefly on the epidemiology of stroke, add a note on prevention and control of stroke. So when you write about prevention and control of stroke, you should be adding what is a national program in our country, that is national program for the control of cancer, diabetes, cardiovascular disease and stroke. So you should write the part of this program which is concerned with cardiovascular disease and stroke. So this would have been very well be explained in national health programs about this particular issue. Thank you very much for your patient hearing. Please do read about this particular chapter, and this is included in your second internal assignment. Thank you very much.